Welcome back to the deep dive. Today, we're really digging into something that causes a lot of frustration, I think, in mental health circles. It's this common idea, this misconception that people dealing with chronic aggression or, really disruptive behavior are just choosing not to control themselves.
Right. Or that they just need, quote, better discipline.
Exactly. But our source material for today, Chapter 21 on impulse control disorders, it really pushes back on that idea pretty strongly.
It absolutely does.
Yeah.
It lays out very clearly that conditions like chronic defiance, ODD, conduct disorder, even uncontrollable rage, like an IED,
Yeah.
these are fundamentally psychiatric illnesses.
They're not just like personality flaws.
Not at all. And they come with huge personal and societal costs. We're talking isolation, school failure, and unfortunately often dangerous run-ins with the criminal justice system if they aren't treated.
So today we're going to map out this whole category: disruptive, impulse control, and conduct disorders. That means looking at oppositional defiant disorder, or ODD,
The more severe conduct disorder, CD.
and intermittent explosive disorder, IED. And we'll touch on pyromania and kleptomania too, because they share that core impulse mechanism.
Yeah, that tension and release pattern. So our mission today is to give you a really solid roadmap. We'll cover how these disorders present clinically.
What the source says about the biological factors, which are actually pretty fascinating, and the environmental risks.
And critically, what this all means for nursing. Assessment, safety, intervention strategies, all pulled directly from this chapter.
Yeah.
Okay, so let's get into it. Where do we start? How do we tell normal kid defiance from, a real disorder?
Let's start with oppositional defiant disorder, ODD. I mean, all kids push boundaries, right?
Yeah.
Especially toddlers, teenagers.
Sure, that's developmentally normal testing.
But ODD is when that behavior really goes over the line. It starts seriously impacting their life at home, at school, with friends, multiple places.
And it's interesting because ODD hits on two levels. There's the emotional side, that persistent anger, irritability.
Like a constant simmering.
Kind of, yeah. And then there's the behavioral side. Arguing, defiance, being deliberately annoying, sometimes vindictive. And the source makes a key point. For it to be ODD, this pattern has to show up with at least one person who isn't a sibling.
That's an important distinction. Fighting with your brother doesn't automatically mean ODD.
Right. Now, there's some good news and bad news here. The source says most kids actually do outgrow ODD.
Oh, really?
Yeah, especially if other issues they might have, like ADHD, get treated effectively. But, and this is the warning, if it doesn't resolve, it could be a direct pipeline into conduct disorder.
Okay, so it can progress. Let's talk about conduct disorder then.
Yeah.
If ODD has that internal emotional piece, the anger and irritability, how is CD different?
CD is where the behavior becomes much more externalized and, frankly, harmful to others, while both involve butting heads with authority.
Right.
ODD has that specific emotional dysregulation component, the anger, the touchiness, which often isn't the main feature in CD. CD is really defined by a persistent pattern of violating other people's basic rights or major societal rules.
So we're talking aggression, property destruction.
Deceitfulness, theft, serious rule breaking.
Yeah, and before we move fully into CD, you mentioned something interesting earlier about ODD potentially lasting longer.
Yes, the source material points out that ODD symptoms can actually stick around into young adulthood.
Yeah.
Think college age.
Wow.
And when it does persist like that, it's linked with pretty significant social problems, ongoing conflict with authority figures, and even, interestingly, a tendency towards being really antagonistic online. It's a sort of modern expression of it.
That makes sense. Okay, so back to conduct disorder, violating rights, breaking rules. The chapter actually lists specific criteria, doesn't it?
It does, and it's quite a list. 15 specific categories of behavior. Things like bullying, physical cruelty to people or animals.
Cruelty to animals is a big red flag, isn't it?
Huge. Also fire setting, deliberately destroying property, stealing things of value, even forced sexual activity. It covers a really concerning range of actions.
And the source talks about different onsets having different prognoses.
Yes, this is critical. There's childhood onset, meaning symptoms show up before age 10.
And what does that signal?
Unfortunately, it signals a much tougher road ahead. It's more common in boys, they tend to be more physically aggressive, and often have really poor relationships with peers.
And crucially.
Crucially, they often lack genuine guilt or remorse. They might misinterpret neutral situations as hostile. And without serious, intensive intervention, this group has the highest risk of developing Antisocial Personality Disorder, ASPD, as adults. That's the really concerning trajectory.
Okay, so that's childhood onset. What about adolescent onset?
That's when symptoms first appear after age 10. The picture here is often a bit different. The behaviors might happen more within a peer group context, risk-taking, maybe substance use, breaking rules together.
Less isolated aggression.
Often, yeah. The ratio of males to females is more balanced too, and generally the long-term outlook is considered better than for the childhood-onset type. Still serious, but maybe a slightly better chance of turning things around.
But there's a specific feature, regardless of onset, that's particularly worrying.
Yes, it's this specifier called limited prosocial emotions. You might hear it referred to informally as callousness.
Callousness.
It's a really strong predictor of future ASPD. It means the person shows a persistent lack of empathy. They're genuinely unconcerned about others' feelings.
Wow.
And they might say they feel guilty, but usually only if they're caught or facing punishment. It's not true remorse about hurting someone. It's a very dangerous sign.
Okay, let's shift gears slightly along this impulse control spectrum to Intermittent Explosive Disorder, IED. What defines this one?
IED is about a repeated failure to control aggressive impulses. We're talking verbal aggression, tirades, arguments, or physical aggression towards property, animals, or other people.
And the key is that the outburst is...
wildly out of proportion to whatever triggered it. Like someone cuts you off in traffic and you go into a full-blown destructive rage.
And there's a typical pattern to these episodes.
Very distinct. The Force calls it the rage to remorse cycle. It starts with this buildup of tension or arousal, maybe feeling increasingly stressed or agitated.
Like in that traffic example.
Exactly. Then comes the explosion, the aggressive act. And immediately after, there's often this sense of relief, like letting off steam.
But doesn't end there.
No, because then the delayed consequences kick in. Intense feelings of remorse, regret, maybe embarrassment about what they did. That's the cycle. Tension, explosion, relief, remorse.
And you mentioned something surprising earlier, a link to physical health.
Yeah, this was striking in the source material. People with IED have significantly higher rates of serious medical problems. Specifically, hypertension and diabetes were called out.
Wow. So that chronic agitation, that stress, it literally damages the body.
It seems so. The constant psychological stress really appears to take a physical toll, especially on the cardiovascular system.
Okay. And then briefly, pyromania and kleptomania. They fit here because of the impulse mechanism.
Precisely. They're sort of classic examples of that core impulse control deficit. In both cases, there's this significant buildup of tension right before the act.
Like an itch they have to scratch.
Kind of, yeah. And then after they act on the impulse setting the fire or stealing the item, there's this feeling of pleasure, gratification, or just relief.
And for kleptomania, the stealing isn't really about needing the object, is it?
Not at all. That's the key. It's the repeated failure to resist stealing things that have no real personal use or monetary value. The book gave examples like, stealing books in a language you can't even read, or baby clothes when you don't have kids.
Right. That really highlights it's the act of stealing, the impulse itself, that's reinforcing, not the item.
Exactly. And for pyromania, similarly, the fires are set deliberately, repeatedly, just for the pleasure, relief, or fascination with fire itself.
It's not about revenge or money or covering up another crime.
Nope. Sometimes the source mentions the person gets pleasure from watching the fire engines arrive or witnessing the destruction. It's purely about satisfying that intense impulse.
Okay, this is fascinating and a bit scary. Let's get into the why. You mentioned biology earlier, and this is where it gets really interesting, right? This isn't just bad behavior.
Not at all. The source material provides clear evidence for neurobiological differences in these individuals. For ODD, for instance, studies show reduced gray matter density in the left prefrontal cortex.
And that's the brain's control center.
Pretty much, yeah.
Yeah.
It's crucial for impulse control, decision-making, executive functions.
Mm-hmm.
So less density there suggests, impaired cognitive control over emotions and behavior. We also see differences in deeper brain structures like the amygdala and insula, less activity, maybe smaller size.
And what about for conduct disorder, especially that callous type?
The differences there can be even more pronounced. Reduced gray matter is found in areas like the anterior insular cortex, which is key for self-awareness, empathy, processing emotions.
Right.
And the left amygdala. And some functional imaging studies are quite chilling. When individuals with these callous traits are shown images of other people being harmed, their brains show less blood flow in the regions normally associated with empathy. It suggests, on a physiological level, they have a reduced capacity to understand or connect with others' suffering.
Wow, that's significant. Are there other physiological markers?
Yes. ODD is linked with reduced cortisol reactivity to stress. cortisol is a key stress hormone. If you react less to stress or punishment.
You're less likely to learn from negative consequences.
Exactly. It can make someone more prone to sensation-seeking, less deterred by potential downsides.
And you mentioned something about heart rate.
Oh yeah, this is interesting. The source differentiates based on resting heart rate and ODD. A high resting heart rate seems linked more to reactive aggression, lashing out impulsively when provoked.
Okay.
But a low resting heart rate was associated more with proactive aggression, the more planned, predatory, calculated kind.
So the biology might even hint at the style of aggression.
It seems possible. Yeah.
Hmm.
It's complex, but the correlations are there.
Of course, biology isn't the whole story. What about the environment? Adverse childhood experiences, ACEs?
Absolutely crucial. The source strongly links all these disorders to ACEs. Things like experiencing parental rejection, neglect, growing up in a really chaotic home.
Inconsistent discipline. Or maybe overly harsh discipline.
Both, yeah. Lots of family distress, lack of a stable, safe psychological environment. These are major risk factors.
And the source makes an important point about cause and effect here, doesn't it?
It does. It stresses that harsh parenting or even child abuse can sometimes be triggered by trying to manage a child who has a very difficult temperament to begin with, or maybe undiagnosed ODD or ADHD.
So it can become this awful feedback loop.
Exactly. The child's behavior provokes harsh responses, which then makes the behavior worse, and so on. But regardless of how it starts, that link between a traumatic or highly stressful environment and these disruptive behaviors is undeniable.
Okay, so given all this, the biology, the environment, the specific behaviors, what does this mean for nurses or other healthcare staff who encounter these patients? How do we approach care?
Well, the first thing the source hammers home is assessment priorities. For any of these impulse control disorders, the absolute top priorities are assessing suicide risk and risk for violence.
Because of the impulsivity.
Exactly. That poor self-control makes them statistically much more likely to act on suicidal thoughts or aggressive urges. You have to assess intent, plan, lethality, access to means.
Even in younger kids who might not fully grasp death?
Especially then, yes. Their understanding might be distorted, but the risk is still very real. Safety first, always.
And beyond immediate safety, what about the nurse's own perspective? These behaviors can be really challenging.
Hugely challenging, which is why the source emphasizes self-assessment for the nurse.
Yeah.
You have to actively check your own attitudes. Are you falling into that trap of thinking the patient is just choosing to be difficult?
Right.
We have to push past that and adopt a trauma-informed care approach. That means shifting the question from what's wrong with you to what happened to you. It fosters empathy and recognizes the underlying issues.
That shift seems critical. Now, managing the immediate environment teamwork. Communication sounds key. The source mentions expressed emotion.
Yes, expressed emotion, or EE. It's basically just how much emotion, particularly negative emotion like criticism or hostility, is shown by staff or family caregivers towards the patient.
And why is that important?
Because the research shows that high expressed emotion, lots of criticism, getting into power struggles, showing resentment is a major trigger for aggressive responses in these patients. It actually increases the risk of violence.
So staff need to keep their own emotions in check.
Precisely. The goal is low or moderately expressed emotion. Stay calm, stay neutral, even when setting limits.
What does that look like in practice? Specific techniques?
Yeah, things like using non-threatening body language, relaxed posture, not crowding them, using a flat, neutral tone of voice, being very matter-of-fact when you need to address behavior or set a limit.
And avoiding personal language.
Definitely. The source says avoid using I or you when setting limits because it can sound blaming. Instead of you need to stop yelling, maybe yelling's not allowed on the unit. Keep it objective.
Makes sense. So the general interventions are about creating safety, building rapport, setting clear boundaries.
Structure, consistency, always following through with stated consequences. That predictability is really important.
And there are specific behavioral techniques mentioned too, like simple restitution.
Right. Simple restitution isn't punishment. It's about having the patient correct the direct negative consequence of their action. If they make a mess, they clean it up. If they hurt someone's feelings, they need to offer a genuine apology. It links the action to its immediate effect.
Okay. Other tools mentioned were things like redirection, modeling appropriate behavior.
And consistent limit setting, using those calm, neutral techniques we just talked about.
Got it. Okay, let's talk treatment. What about medications?
Well, first off, it's crucial to know the FDA hasn't actually approved any medications specifically for ODD, CD, or IED themselves.
So any medication use is off-label?
Entirely off-label, yes. Meds are used to target specific symptoms, mainly aggression, irritability, and impulsivity.
What kinds of meds are used?
For ODD, the mood stabilizer divalproex sodium, Depakote, is mentioned for reducing that reactive aggression and irritability. For aggression and conduct disorder, you often see second-generation antipsychotics like aripiprazole, Abilify, or risperidone.
And for IED?
For IED, SSRI antidepressants like fluoxetine, Prozac, or citalopram, Lexapro are often used, sometimes along with a mood stabilizer.
Is there anything clinicians should definitely avoid?
Yes, a big warning flag in the source is about benzodiazepines, drugs like Valium or Xanax,
Why?
because they can actually lower inhibitions and reduce self-control even further, which is the exact opposite of what these patients need. It can potentially make impulsivity worse, so generally avoided.
Good to know. What about psychological therapies?
CBT, cognitive behavioral therapy, is often used, as you might expect, but the source also highlights DBT, Dialectical Behavioral Therapy.
Why DBT specifically?
Because DBT puts a strong focus on skills training for emotional regulation, distress tolerance, and mindfulness, all things that directly target poor impulse control.
Makes sense. And for younger patients, involving the parents is key.
Absolutely essential.
Mm-hmm.
The source talks about parent management training, or PMT. This basically teaches parents more effective ways to use discipline, set boundaries, and encourage positive behaviors.
And there was another parent therapy mentioned, PCIT.
Yes, parent-child interaction therapy. This one's really interactive. A therapist coaches the parent, often through an earpiece, while the parent is actually playing or interacting with their child.
Wow, real-time coaching.
Exactly. The therapist gives immediate feedback and guidance on how to manage behaviors and strengthen the positive connection. It's shown to be very effective.
And for the really tough cases, like violent juvenile offenders.
Then we look at multisystemic therapy, or MST. This is described as the most intensive approach. It's family-focused, community-based.
Works across different systems in the kid's life. Right. School, home, peers. The goal is often to replace involvement with delinquent peers with healthier activities, improve how the whole family functions, and provide really intensive support, almost 24/7, to break that cycle of violence.
It sounds incredibly comprehensive.
It has to be, for those complex situations.
Okay, so wrapping up this part of our deep dive.
Yeah.
We've seen how these aren't just choices, but have real psychiatric and biological roots. We've moved from ODD's defiance and emotional struggles
To CD's more serious violation of rights, especially watching out for that callousness trait.
and IED's explosive cycle.
Yeah.
And the absolute need for safety assessment first and foremost, plus that crucial shift towards trauma-informed care.
Exactly. Moving away from what's wrong with you towards what happened to you.
So as we finish up, maybe a final thought for our listeners to consider, building on what we've discussed.
Well, you mentioned the connection between IED and physical health earlier, but let's bring in trauma again.
Yeah.
The source highlights a really high overlap between intermittent explosive disorder and PTSD, especially noted in veteran populations.
Okay. And here's the really sobering statistic from the study cited. When someone has both IED and PTSD, the rate of suicide attempts was alarmingly high, 41.4% in that specific sample.
41%.
Yeah. So that one data point really drives home how tightly interconnected trauma, aggression, impulsivity, and self-harm risk can be in this population. It just reinforces, yet again, why continuous vigilant screening for both violence risk and suicide risk is absolutely non-negotiable whenever you encounter symptoms of impulse control disorders. Early intervention and ongoing assessment are just critical.